Hello, everyone, and thank you for joining the Policy Lab webinar series. Policy Lab is a research center within Children's Hospital of Philadelphia's Research Institute. Our care for children and families drives our research, informing practice and policy to improve child health. Slide. This webinar series is just one of the many tools we use to translate the work under our 5 research portfolios into evidence-based policy solutions at the state, local, state, and federal levels. Today, we'll be focusing on connecting refugees to evidence-based PTSD treatments. Slide. A few housekeeping items. First, feel free to submit your questions to our presenters using the Q&A feature on the right side of the platform. We'll do our best to answer them during the question and answer portion at the end. If you are having connectivity issues, we recommend disconnecting from your VPN. You can find this webinar archived on Policy Lab's YouTube channel and on our website at policylab.chop.edu tomorrow. Slide. Now I'm going to pass it over to Policy Lab researcher Dr. Kate Yoon to get us started. Kate?
Thank you so much, Catherine. My name is Kate Yoon. I'm a general pediatrician at Children's Hospital of Philadelphia, where I work as a researcher in Policy Lab and a faculty member in our Refugee Health program. I'm also the fellowship director for our academic general pediatrics training program. It is really an honor to be with you today to talk about PTSD, improving communication and care for refugee patients. I'm especially pleased to be here with my collaborators, a wonderful group of experts in refugee community services, mental health, language services, and community health. We have no financial conflicts of interest to disclose. The work we're presenting was supported by PCORI. After the webinar today, we hope that you'll be able to describe common communication missteps in discussing mental health care with refugee patients, advocate for evidence-supported PTSD treatment for refugee adults, and demonstrate effective communication skills to help refugee patients, clinicians, and interpreters feel more comfortable with mental health referral and treatment. To get us started, I'll transition over to my colleague, Mr. Gurung. The Nepali-speaking Bhutanese refugee community is one of 4 language communities that we focused on for this project, although we believe the broader lessons learned are generalizable to other refugee and immigrant communities as well. Mr. Gurung will offer context on why we believe it is so important to prioritize good communication regarding mental health care. Mr. Gurung, the floor is yours.
Thank you, Dr. Yoon. Hello, everyone. My name is Ashok Gurung, and I'm a former refugee from Bhutan, resettled in Pittsburgh in 2009. Currently, I'm working partly as a clinical research assistant at the Policy Lab in the Children's Hospital of Philadelphia. I'm a certified instructor for both youth and adult mental health curriculums and have been conducting the mental health first aid training to the Bhutanese communities across the United States and locally to nonprofit organizations, including some faith groups. By now, I have been able to train over 1,000 participants. This has been a very significant experience, having the opportunity to talk to people in different parts of the country and hearing their diverse experiences, perspectives, and how they have managed to cope up with. Sometimes I work directly with the individuals having mental health crises, connecting them with professionals for help. It has been very rewarding to bring smiles in those folks. Besides, I also co-founded the Bhutanese Community Association of Pittsburgh, which has been doing very well in the region, helping thousands of people, collaborating with the many different partners in the region. Next slide, please. So Bhutan and its refugees. So first, I'm sure for many of you know where Bhutan is, but for some it could be unheard of. So I have it for you in short. When you look at the left-hand side of the screen, you can see small reddish shaded area in between China, yellow in the north, and the green shaded region in the east, west, and the south, around this red shaded area, which is landlocked country, Bhutan. In between 1990 and 1995, there was a huge exodus of the mostly southern ethnic Nepali-speaking Bhutanese citizens. 1/5 of its population had to leave the country, and around 2/3 of the refugees arrived in the camp in Nepal, and 1/3 of them did not make it for various reasons. This is the time when many family members were separated, jailed, tortured, lost, or killed. Looking at the right side of the screen, there are refugee camps that you could see as dots in the gray shaded area 1 to 7. You can also see the index at the side. Nepal refused us on the humanitarian basis. Nepal is not. This is because Nepal is not mandated to provide refuge or asylum to anyone, since it is not signatory to the Refugee Convention and Protocol. There were actually 15 rounds of talks between Bhutan and Nepal for the repatriation of these refugees, but did not resolve the issue. So primarily, people lost their citizenship, their properties, and their country. But more importantly, there were secondary losses, such as rural community bonding, farming, their place, and environment for entertainment and celebration. Next slide, please. So Bhutanese refugees in Nepal. So during those long years of stay in refugee camp, the Bhutanese refugees lived in harmony, supporting each other. People were very empathetic. Whenever there was any kind of crisis, the victim family did not have to suffer alone. The neighbors, relatives, and friends, as well as those unknown came for help. Emotionally, this community is very connected. Of course, bystanders can't be avoided, but I hardly saw people, just going away from the responsibility when they saw people in crisis. In the meantime, people were able to highly educate their children. Again, getting financial support from others in the amid the financial strain. Our people are culture lovers, and when we refused to give up the cultural values that we had, we suffered. Over 25 years of stay in the refugee camp, non-violence was the rule of law. There was hardly any organized violence from the refugee camp itself. Next slide, please. So refugee camp and mental health problems before resettlement. So, not only the atrocities faced by our people, but the situation in the camp was equally tormenting. Refugees were provided with charcoal briquettes for cooking. The whole camp would be under the cloud of smoke in the morning and the evening. Likewise, we used the kerosene lamp to study at night, that you can see the screen. This charcoal and the lamp ignited fire to a heart. But since the hearts were too close, the fire got into the other hearts, and thus the whole camp would be swallowed by fire. In one of the incidents, to be exact, 1,284 families lost their home at a single event. This type of fire events was very frequent. Nothing was safe in bamboo-walled and thatched roofed huts. People not only got injured, but also lost their family members in some fire events. Next slide, please. Mental health challenges in the refugee camps before the resettlement. So this is, here I would like to refer a large study that underwent psychiatric interviews as a research protocol conducted in 1995. This was done among those who arrived at the refugee camp in between 1991 to 1994. Among those torture refugees, their lifetime prevalence of the PTSD is close to 3/4. You can see that it is 73.3%, while those non-tortured, the lifetime prevalence is 14%, which is still high, like 14 in 100. These statistics reflect one of the typical examples of the refugees' mental health situation. So, point to note, the stigma attached, the sexual abuse, the rape were never expressed. There is more cultural part playing it. Thus, these folks have a deep traumatizing experience. I'm not sure if these issues were professionally addressed in the refugee camp. However, during those stay in the refugee camp, there were another bonding established, and I hope this might have played some positive role in the healing process. Like this. Bhutanese refugee resettlement, how did it take place? So in 2006, the United States declared that 60,000 of the refugees would be resettled in the US, but the number won't be the cap if more refugees would express interest. By 2007, resettlement process started, and by 2009, 7 other countries stepped in to be part of the resettlement process. Today, over 96,000 of the Bhutanese refugees are resettled only in the United States alone. Next slide, please. Post-resettlement challenges, as refugees have to face many unexpected events and painful in transition process. Like I stated earlier, the mental health problems is commonly seen among the refugees. So is the situation in the Bhutanese refugee communities. After the resettlement, there were a high rate of suicide among the resettled Bhutanese refugees. CDC did a study in 2012 and found out that average adjusted suicide rate was 12.4 per 100,000, while those suicide rates are in the general population was only 12.3 per 100,000. The other study published in 2015 showed that 4.5% of the Bhutanese refugees were still found to have PTSD. So there were episodes of traumatization, including one that would have been triggered due to the post-resettlement situation, such as the language problem, navigation, unemployment, substance abuse, domestic violence, including the COVID-19. Next slide, please. Trauma in Nepali-speaking Bhutanese refugees. With the above setting, I would like to present a case in Nepali-speaking Bhutanese refugees with a PTSD problem. Identifying information has been changed to protect the privacy of the individual. This is a composite of different cases. The case details are, the key details are based on key experiences. I want to use a pronoun he here for the convenience of my today's presentation. Next slide, please. So from Bhutan to the US, this individual, so one of the parents was jailed in Bhutan for over 10 years. This was for political reason. Anyone jailed in Bhutan would be tagged negatively and tabooed when the family members, then the family members would be harassed. When there was no security, the challenges and the challenges to the other parent, the family, the parent living with the children, it led to the parent's ultimate separation, leading to this parent to leave the child himself again. So as a minor, this individual, he fled fearing for his life. As a child living on his own, he experienced all kinds of abuse. He attempted suicide at an early age. To make a story short, he got resettled in the United States as a young adult. However, the system navigation was hard. Healthcare, employment, and hearing the gunshot at his neighborhood made his problem even worse. Next slide, please. PTSD diagnosis and therapy. With when he visited his primary care doctor with physical illness, his doctor introduced with the idea of PTSD. After many conversations, he decided to seek for PTSD, seek help for PTSD and depression. At first, the treatment seemed promising. He worked with one therapist and one interpreter. I think this is a point to note for everyone. He was offered evidence-based psychological therapy, and things seemed to be working well. But after a month or so, the therapist was changed. The interpreters were different, leading the communication to break down. Some of the new interpreters used language, that was technically correct, felt harsh and stigmatizing. Next slide, please. So over the time, he lost patience and confidence. Like there were problems in his family. He was very angry all the time. The family felt unsafe. He felt like being labeled crazy. Eventually, he came to low therapy and stopped going. His PTSD has not been resolved yet. He frequently sees the primary care doctor for somatic complaints. So this is all about the story. I hope you'll remember this story to connect with the upcoming presenters' content. I'm now going to turn it over to Dr. Linda Mikoder. Dr. Mikoder.
Hi, thanks very much, Mr. Gurung. Next slide. And I think maybe the next one as well. Hi, I'm Linda McWhorter. I'm a licensed psychologist, and I'm an assistant professor in the Institute for Graduate Clinical Psychology at Widener University. And unfortunately, the case example that you just heard is common among refugees, illustrating the need for effective PTSD treatment. Next slide. It also illustrates the importance of clear, culturally tailored communication when discussing mental health in refugee populations. However, there are a number of health system barriers that reduce access to treatment for refugees. Primary care clinicians may not know about effective PTSD treatments, and primary care and mental health clinicians may use mental health jargon that's difficult to interpret. Also, terms used to discuss mental health can be highly stigmatizing. These clinicians may also make assumptions about culturally bound concepts related to mental health, like the concept of PTSD, or the concept of even getting mental health therapy or medication to support healing from traumatic events. Also, mental health clinicians are taught not to work outside our scope of practice and to use evidence-based treatments. Therefore, if a mental health clinician is unfamiliar with the evidence, they may assume that they're not qualified to treat refugees. Next slide, please. In addition to health system barriers, some refugees were denied education due to oppression in their home country, or were unable to access formal education because they were fleeing from violence throughout their childhood. And so they may not be able to read in their native language. They also may have limited health literacy, especially with limited exposure and understanding of the U.S. healthcare system. Refugees may have differences in their understanding of what causes mental health problems and how those might be treated. And these factors together with existing healthcare system barriers work to reduce access to mental health treatments among refugees. And importantly, it limits refugees' opportunities to heal from the trauma that they've experienced. Next slide. So what do we know about PTSD treatments? The PCORI, or the Patient-Centered Outcomes Research Institute, conducted a recent exhaustive review of PTSD treatments, and they found several evidence-based psychological and pharmacological treatments that effectively reduce PTSD symptoms and can even eliminate the diagnosis of PTSD in a wide variety of patient populations with a wide variety of traumas. And these treatments were found to have minimal potential for harm. Next slide. We suggest that practitioners use treatments that have moderate to high strength of evidence. All of these psychological treatments meet the criteria. Each of these uses a form of exposures through imagining, writing, or talking about a traumatic event in a safe way. This helps patients to reduce the avoidance of the reminders of the trauma and the emotional and physiological reaction to these reminders. Next slide. These medications had moderate strength of evidence, including the SSRI fluoxetine and the SNRIs paroxetine and venlafaxine. We will now discuss the resources that we developed to disseminate this information to clinicians, interpreters, and community leaders. Next slide. And you can advance it one more. So Dr. Kate Yoon developed the initial plan to provide guidance on how to talk with refugees about PTSD. We partnered with key stakeholders to develop and disseminate materials to clinicians, interpreters, and refugee community leaders. First, we used the PCORI PTSD evidence, which is a 600-plus page document, and condensed that into 3 pages that was easily accessible that clinicians can access during a clinic visit. Next, we generated a glossary of 41 words that may be used in discussing PTSD with refugees. We selected the 4 most spoken languages by refugees in the state of Pennsylvania, listed here, and we worked closely with our translation teams to translate this vocabulary into understandable language that will avoid miscommunication and stigma. Next slide. In our evidence summary, we highlight the evidence specific to refugees. Some important points include that PTSD is common in refugee populations, it's treatable, and importantly, evidence-based practices that work with U.S. English speakers are also effective with a wide variety of refugee populations and the types of trauma they experience. Also important is that the psychological treatments are effective whether they're delivered through a bilingual clinician or an interpreter. Next slide. Next, we worked with our translation teams to develop the translations for the glossary terms aimed at reducing potential stigma and miscommunication. For example, PTSD is a concept that's often understood in the US, but it does not translate easily. The word avoid, we spent almost 40 minutes with some of our translation teams talking about how to translate this one word. In the PTSD context, it refers to avoiding reminders of a trauma that are not in and of themselves dangerous, like a soldier avoiding fireworks. The translation teams offered a version of the word that meant to stay safe or keep yourself safe from. And after much discussion, we realized that some of the team members felt that avoiding trauma reminders is a way to stay safe. So helping translators understand this distinction helped us to avoid further miscommunication in clinic visits. Also, the word intervention in Swahili literally translates to mean meddling, which can have real negative connotations and can be a real barrier to treatment if a patient is told that someone wants to meddle in their business. Early on in this project, we have experienced some unexpected positive impacts. Our translation team members have reported back, several of them, that at first it was just a translation assignment, but that it ended up transforming into a real great learning experience for these teams. Understanding how to help their community avoid some of the stigma involved in words related to mental health was a rewarding experience for a lot of our team members. Next, we had community member checks where our translation team members talked with members of their communities about the translations to see if the words we chose were going to be effective at communicating the ideas. One team leader reported that she described, as she was describing mental health problems as a treatable condition, a community member said to her, "Oh, you mean it's just like heart disease and I can go to a doctor and get better?" So talking to community members about these glossary terms turned out to actually help reduce stigma around mental health. And one of the medical clinicians who provided us feedback on an early version of the evidence summary said that he used that information that same day with a refugee patient. I'm going to now turn it over to Dr. Priscilla Ortiz to describe more about our glossary. Next slide, please.
Thank you, Dr. McWhorter. My name is Priscilla Ortiz. I'm an applied linguist and a CMI Spanish certified medical interpreter. In my current role, I'm the program manager for language services at Children's Hospital of Philadelphia. Next slide. Oh, sorry, not next slide. I'll be sharing about the PTSD glossaries, how the tools can be used, and some tips for communication in the context of multilingual, multi-party dialogue. The glossary aims to offer accurate and comprehensible translations which consider semantic meanings as well as connotations. The glossary presents one or more descriptive phrases for any entries where the translation team did not find a suitable equivalent. We also intend for this document to help make it easier to discuss PTSD by standardizing the language around diagnosis and treatment. As more interpreters use the glossary and select translation options accordingly, the more standardized and eventually recognized terms become. Another important purpose with these glossaries is to identify and share any strong translation preferences among the refugee communities themselves for either using or avoiding specific terms. Next slide. We have the same 40 terms appear in each of the 4 glossaries. The table of contents is alphabetical. The electronic version is searchable. Within the main pages of the glossary, terms are listed in categories so that related words appear together in each of the following sections: symptoms and assessment, trauma, mental health professionals, treatment, and psychotherapies. Let's look at a sample entry. Next slide. One thing that sets this glossary apart is that it contains supplemental information that goes beyond what we would find in a typical bilingual dictionary. The first line of the entry is the term itself, as shown here, circled in red. Next slide. In the same column as the term, just below it, we have an in-depth definition, which is not meant to convey every possible definition or even most uses of the term. Instead, we focused on the typical meaning within the context of PTSD-related talk. In this case, you can see the anxiety entry includes the definition and an explanation of the term, and then more information to differentiate degrees or different types of anxiety. Next slide. In the second column, we've added a bit of context for the use of each term. These are example sentences which show how the term could come up in a conversation around PTSD screening, diagnosis, or treatment. Then, in the column on the right, we have one or more translations for each term. Translation entries are numbered and appear in the corresponding script of each language. Any of the translations may be followed by a version of the term written in the Latin alphabet, but this only appears if this kind of romanization is used by members of the community. It's not considered to be any kind of pronunciation guide, but just a reference point for community members. Following the translation, we often have an English gloss, that is, a brief meaning of the translation, especially when no exact equivalent in the refugee language was available to the translation team. This can be helpful to clarify nuances among the terms or when a descriptive phrase is suggested. As we show on the slide, the first two translations of anxiety are glossed in English as worry, but number 3 is a phrase glossed as fear about the future. Next slide. Lastly, below the translations, many entries contain additional community notes or usage notes. This section speaks to the limitations of specific translations, such as potentially stigmatizing connotations or usage that may be typical only among subgroups, people of a certain age or people from a certain region. This way, the glossary user gets candidate translations, but also reasons to avoid or a particular term if it's not suitable. We do see it as the task of the interpreter to not only provide accurate and faithful renditions of what is spoken, but in doing so to use critical judgment and their own experience in selecting terms and making adjustments as necessary in order to support the rapport, conversational flow, and the needs and goals of the participants. Next slide. Our hope is that these tools serve to help expand the knowledge, confidence, and comfort level of interpreters when it comes to mental health and PTSD. Both the evidence summary and the glossary can be seen as a knowledge base and a resource to assist in selecting those terms that will be most appropriate for a given situation. Keeping it handy will be key, whether you prefer to work with an electronic copy on your device or a hard copy that you physically take with you to appointments. You may also see it as a reference to review ahead of time to help you prepare for whatever might come up in conversation. The more we use the tools, the more comfortable we can become with the terms and concepts. Next, we list some best practices for clear communication among clinicians, interpreters, and patients. Next slide. We have a couple of strong recommendations. First, we cannot overemphasize the value of a pre-session briefing in which clinicians and interpreters take a moment to discuss what they may need from each other to keep communication clear. This briefing can be the first step towards establishing essential trust between clinician and interpreter, which then supports the development of a trusting relationship with the client, patient, or family. Another way to support clear communication is to use plain language whenever possible. In PTSD terms, with the term trigger as a verb, we mean to bring up upsetting memories involuntarily. Now, this is a technical meaning that originates with the metaphor of the setting off of a firearm, and it can be a challenge to translate accurately and succinctly in the pressure of the moment. And we should know that translating literally or including the original metaphor as part of the explanation could also unwittingly become a trigger. A clinician or interpreter might come up with a plain language word or a phrase that substitutes for a technical term. For trigger, it might be a sudden reminder. So that's a possible way to translate, but it doesn't cover the full meaning of what is meant by trigger in this case. So even though it may be a useful phrase in the moment, it's important to remember that the full meaning may need to be reestablished in future conversations. And in an effort to create an effective rendition from the start, an interpreter may ask a clinician to define or describe technical words like trigger. So what does plain language look like? The next slide has a couple of examples, although the variations are as endless as our languages permit. Next slide. The two sentences in the left-hand column are contextualizing example sentences from the glossary with the terms trigger and process as verbs with technical meanings. In the right-hand column, we have a few plain language options for each. Some are English glosses of translated text. The example on the lower part of the slide is for the term process. The specialist can help you process these traumatic experiences. We can put this differently in plain language. For example, the specialist can help you heal from these traumatic experiences. The specialist will work together with you step by step for a change with these traumatic experiences. Now, as you can see, it can take some effort to transform our usual shorthand into plainer language. But you see the results are also so much more translatable and more relatable. This work of making jargon plain is something interpreters and clinicians may need to do frequently. And the job of making implicit information more clear, that is, more explicit, usually takes more words to communicate in another language or culture than how the thought was expressed in its original language and culture. With this in mind, if an interpreter is speaking for longer than you expected, it may be that they're transforming a technical or cultural concept into everyday language. Next slide. We encourage clinicians and interpreters to share this evidence summary and glossary with colleagues in medical and mental health. We urge you to use the evidence summary in recommending and providing treatment to refugees and asylum seekers. Mental health treatment remains stigmatized, and therefore normalizing mental health conditions as a form of chronic illness for which treatment improves well-being can improve communication and may improve treatment adherence and outcome. Again, use plain language as often as possible, offer explanations with complex terms. Note that patients may be more comfortable speaking openly about mental health after they have developed a caring interpersonal relationship with a clinician. Many women may be more comfortable speaking openly with gender concordant clinicians and interpreters. Next slide. A few final tips or reminders. Again, the most important thing we can recommend is that you invest the few minutes it might take to connect with the interpreter if you are a clinician, or with the clinician if you are an interpreter. Use the briefing time to share goals for the session. The better an interpreter understands what you're trying to accomplish, the more accurate the interpreting can be. Clinicians can state potential topics to be discussed or what terminology might be used. Consider whether the conversation may present triggers for the interpreter. The interpreter may or may not have a similar cultural background or life experiences as the patient. Either way, trigger warnings may be helpful. Clinicians can inform the interpreter about any behaviors that a patient may exhibit. Interpreters can let clinicians know about your style of checking in or a signal you may want to use to ask for clarification or offer relevant cultural information when it's really needed. Interpreters can remind clinicians to stick to one complete thought at a time, to avoid questions with 2 and 3 parts to them, to speak directly to the patient rather than the interpreter. We all have the tendency to address the person providing information, which is often the interpreter. But as you all know, it's essential to build rapport with the patient or client. See the interpreter as part of the team. An interpreter is always going to know more than what they were able to say in their translation. We all know it's not only what we say, but how we say what is meant. Think of all the implied differences in English between greeting someone by saying, "Yo man, what's up?" versus "Good evening, how do you do?" Our communication choices display our perceptions of any given situation, and they identify how we are relating to others around us. Some elements will be lost in translation because there's simply no opportunity to go into all of the deep cultural nuances. And our plain language translations may lose something of an individual's uniqueness. But this may not be lost to the interpreter, who is exposed to more information than they can immediately convey. Clinicians and interpreters can also have a debriefing moment after the session to check in about concerns or observations. That may be helpful to each other, and interpreters may not be readily able to offer that information if it's not sought out by clinical staff. Clinicians may want to debrief about whether the patient appeared to understand or if they seemed agreeable for the sake of politeness. Could they have been offended by anything was said? So debriefings can be invaluable. Side conversations can put the interpreter in a very awkward position. Jokes really don't translate because they are cultural more than anything else. And as we've been saying, avoid idioms, metaphors, folk sayings, as all of these are the opposite of plain language. Lastly, keep in mind that speaking versus reading and writing are different skills. We should never automatically expect that an interpreter has been vetted for both interpreting and translation. And written translation should only be done by a qualified translator. Let me just add here that Google Translate and other digital translators have not yet been qualified. You should not trust an electronic translator for any document that represents your organization unless you will have the final version edited and proofread by a qualified human being. Our technology is advancing, but contrary to our popular expectations, it has not surpassed the human knowledge that is essential for quality communication. Next, we have case study information on successful communication among a refugee, her clinicians, and an interpreter. I turn the session over to Dr. Patty Stubber. Next slide.
Thank you, Dr. Ortiz, and good afternoon, everyone. As she mentioned, I'm the Chief Executive of MEDS, a small FQHC lookalike health center located in Erie, Pennsylvania. MEDS was founded in 1972 as a mission of the Erie Diocese and Erie Council of Churches to provide health education to migrant and seasonal farm workers. Once the need for primary care was identified, MEDS began offering health services to everyone, regardless of their ability to pay. MEDS then entered Pennsylvania's Refugee Resettlement Program as a contracted healthcare provider for Region 5, and that was over 10 years ago. We currently conduct the required initial health screens for all incoming refugees who resettle in Erie. We also provide immigration physicals. As a result, 80% of our patients are better served in a language other than English, and our staff mirror our patients with respect to racial and ethnic origins. As part of my duties, I oversee the Quality Improvement Program, and am also responsible for a portion of case management with respect to assisting with citizenship achievement. One of our patients was having difficulty learning and remembering her civics lesson. Next slide, please. She attributed it to an automobile accident that she'd had a couple of years ago. In reviewing her case to complete a government form, I found a more plausible answer. As I mentioned, she was from Somalia and in her mid-40s. The diagnoses that I was reviewing for this form included multiple chronic pain conditions, a number of visits to the ER with that type of thing, so in other words, somatic illnesses. I knew immediately when I saw her name, and then I looked in her pre-departure physical, this woman, being from Somalia, and 98% of other women in Somalia in her age group have experienced class 3 female genital mutilation, or it's sometimes called female genital cutting, and the technical term is infibulation. FGMC is a cultural practice that not only has no health benefit, but it results in physical complications and sometimes mental health issues. FGM can happen anytime from infancy to about 15 years old, but in this woman's case, and also in her interpreter's case, they were both 7 years old when it happened. Some of the long-term effects of FGMC include, as far as mental health issues go, include post-traumatic stress disorder, anxiety, and depression. After review of her chart, I gave it to our chief medical officer, who then reviewed and contacted and referred this woman to one of our mental health providers for an evaluation. The appointment was arranged through an interpreter, that interpreter who happened to be a trusted female interpreter who also experienced infibulation. Next slide, please. And if you recall the diagnostics from Dr. McWhorter, this patient was confirmed as having PTSD using the checklist and extensive interview with close observation. And this was administered through that same interpreter. And again, remember, she also experienced FGM. Next slide, please. The patient went on, once the diagnosis occurred or was confirmed, she went on to have cognitive behavioral therapy with mixed interventions. And those interventions included supportive insight therapy with mindfulness, non-judgmental interviewing with close observation. The patient interview consisted of her telling her story of the cutting experience as a young woman in Somalia. And again, this was conducted with the assistance of that trusted interpreter. The pharmacological treatment that was ordered for that patient included SSRI, paroxetine. And as you know, if you've been a prescriber of it, it requires a great deal of explanation about the treatment and the proper administration. And that was all done through that trusted interpreter. Next slide, please. To date, the patient continues to show improvement, and that's demonstrated by her weekly visits with the psychologist utilizing that interpreter. And just another note is that we do know from the literature that women who have had an FGM experience also have mental health issues at a rate of about 30%. And some of those can include, as I said, PTSD, anxiety, and depression. And to date, there has not been much in the way of quantitative studies. And also, the class 3 FGM is the most severe and physically damaging type of FGM. Next slide, please. I would like to turn it over to Mr. Gurung again. Okay.
Thank you, Dr. Stubber. Thank you also, Dr. McWhorter and Dr. Ortiz for the detailed presentation on PTSD, that PTSD is treatable and how the screening and the treatment process would be improved in the refugee population, including the use of culturally appropriate terms with instances and recommendation. Having the experience of a refugee myself, interpreter, and getting to work with the team has been an honor and a great learning experience for me. I'd like to thank all our partners, METS Incorporated, PA Refugee Health Program, Widener University, all the interpreters and the funders. We are now transitioning to the interactive portion of our webinar, and we would like to welcome your question, reflection, and suggestion. As a reminder, we have these resources, PTSD summary and glossaries online. You may download and share with others as well. Also, please feel free to type your comments and questions on the Q&A box so that our moderators will be able to see them. As a reminder again, when you are asking questions, our presenters were Catherine Yoon, a general pediatrician, and myself, mental health first aid instructor from Bhutanese community, Linda McWhorter, a psychologist, and Priscilla Ortiz, a certified medical interpreter and applied linguist, and Patty Stubber, CEO of FQHC Primary Care Clinics. Thank you all very much for taking your time to listen to us. We deeply appreciate your value and value your presence. And now the floor is yours. Thank you so much.
The first question, I believe, is for either Priscilla or Linda.
Oh, hi. So our first question is, what methods of translation were used here, such as forwards only or forwards and back translating? Maybe Priscilla, this was a good one for you.
So Linda and I and Dr. Yoon all worked closely with the translation teams, and the teams were composed of 3 members each for each of the 4 languages. The teams worked on forward translation individually. The individuals of each team worked on forward translation, and then they met to resolve differences in any of their translations. And then these translations, when the consensus was reached for each of them among the group, then we involved them in a process of checking with the community members so that all of the translation candidates or candidate translations were tested or presented to community members of each language group. And those community members voiced opinions about whether those potential translation options were understandable and whether they would be find them questionable or offensive, and other nuances about the ways in which those phrases or words were understood by community members. And then once that information was gathered, it was taken into consideration, and changes in the translations were made according to the preferences of the community members, and those are included in many of the notes that appear in the translation. I know Dr. McWhorter may want to add to that description.
I just wanted to say that Ashok Gurun also played a very central role in working on the translations. We started with the Nepali document, which he was the team leader for that document, and then he worked closely with our other translation team members to complete the remaining 3 language translations.
Thanks so much for that, Priscilla and Linda. There's another question that has to do with communication across language differences. And this might be a good question both for Priscilla and Ashok, which is, how do differences in nonverbal communication pose challenges? And I guess the related question, and I would include Linda in this, is how do interpreters and clinicians adjust for those kinds of nonverbal communication?
Let me go ahead first, and then you could add on to that. So I think that question is very genuine, and we know that with just the words, we can't tell like how that would impact to the communication. But I know that as an interpreter, like even sitting in front and looking in front of the eyes of the patient directly would make a lot of difference than sitting at the side. So I think, especially in the mental health setting, it is said that not to sit directly in front, but then like sit at the side and communicate. So, but there is also like more kind of psychological perspective that I think Dr. McWhorter would be able to add more.
Yeah, I can talk about, and Priscilla probably has some pieces to add as well, but I think as a clinician working with an interpreter, that pre-session briefing can be a time where you may ask about if there are any nonverbal communication differences that are important to know going into the session. And then also just being open and willing to learn. I think one thing that came out in many of our, I think almost every one of our translation teams, was the importance of developing a relationship with the patient prior to going into personal information. And I think in the United States, people prefer that, but we also accept a provider coming in and going straight to the business and the questions at hand. I think that a lot of these refugee groups, that is a faux pas that might make it difficult for the patient to trust you. So I think it's even more important to do some of the kind of relationship building up front. And Dr. Ortiz?
I would just add that we really generally notice a difference in nonverbal communication when it impacts the flow of the current conversation. So it's going to be something that we notice is maybe not according to the rules that are implicit. We don't talk about these rules generally in a conversation, but these nonverbal behaviors that we do use are a kind of a defined set in each of our own mindset. And when something happens outside of that, then we say, oh, there's something going on here that is not what I am expecting. And when we notice in that moment that something's not going the way we're expecting, that is the moment where we can take a step back and say, I think that something may be going on here that I'm not understanding, and be very willing to address it in the moment, in the most sensitive way, and knowing if you have a trusting relationship with the other members of the group, then knowing that can be handled also in a sensitive way, and stating that that's the intention is helpful. So because sometimes it may be hard when we don't know what the language cues that we see, how to read them. If we're not understanding, then certainly we can work on that together and address it together.
I think these responses really build towards one of the other questions that I see coming up commonly in the chat. And I want to thank the audience for all of your wonderful questions. And we apologize if we run out of time and can't get to them all. But I do see quite a number of questions in which people are asking for more details on how to hold that pre-session effectively. What to do, for example, if you're the interpreter and the clinician does not suggest it. What to do if you don't have a separate space separate from your patient care area. Is it appropriate to have that pre-session in the room in front of the patient and family? And so perhaps Priscilla, Ashok, Linda, if you want to say a little bit about your experiences or recommendations for that pre-session.
If you're the interpreter and you would like to have the pre-session and you see that the clinician has not initiated that, and you can catch them before you begin and are in front of the patient, then you could ask simply a question, can I have a moment of your time? Do you mind if we just touch base briefly before we begin? And just ask the question and then open up the space for their response. More than likely, they're going to say, they're going to give that to you in that moment. On the other hand, if you're already with the patient family, there's absolutely every reason to ask the same question, but be transparent and also interpret what you are asking to the family. You can prepare a statement if you don't already have a quick briefing introduction of yourself as an interpreter, and say that to the clinician, even with the family there, and then let the clinician know that you're also going to say the same things to the family or the client who is present. Certainly, one of the things that creates the most trust is that the communication is transparent and everybody knows in the moment what is being said, or they get the translation, that you interpret back for everyone what is being said, so that there is no perception of the side conversations, which could then lead to distrust. But you can have that conversation, and probably if you're in front of the client or patient already, the clinician wouldn't be mentioning things that they wouldn't want interpreted, because you've already told them, I'm going to be interpreting absolutely everything we say. So those are the kinds of things that can help support making that little entryway into opening up for having a briefing. Ashok or Linda?
I'm just briefly going to jump in. I've often stepped just out into the hallway to review some of the vocabulary or the point of the session and exactly what I want an interpreter to do. And I work with children and families, and so I often have to just be very clear that everything I say to the child I want interpreted, as well as what I say to the parent, and just to clarify the expectations for the session.
And Ashok, if you care to add to these recommendations, there have been a number of questions that have also asked, how would you handle this pre-session for a telephonic interpreting encounter? So I don't know if you feel comfortable addressing that as well.
So first of all, going back to the first question, that is it okay to ask in front of the patient's family? So with my experience working in the Bhutanese community, I may not be able to speak to all the population, but it could be generalized for most, for many immigrant population, that speaking in front of the population, in front of the family members sometimes could be a little bit, not transparent in the side of the patient, because, there is a chance that the family members would say, like, I told you, like, you're having some problem, and see that the doctors are saying the same thing. So that is very probable. So because of that, they worry about being stigmatized from the family members or the relatives. So I think if it is okay, so I think we need to be very transparent that we need to ask that to the patient first. And also, like, interpreting sometime for the clinicians to note it down that, to be more culturally appropriate, we will be translating, interpreting that language to the other language, but using more longer sentences than what the physician had spoken at first. So that might also be a problem for some, like the clinician may think like, oh, I did not tell that long, and he's telling that long, but with our notes in the glossaries, you might be able to understand that part. In terms of over the phone interpretation, I think sometimes the tone is more important. Now we also have the video interpretation over the phone now. I think that will be very helpful. But one thing that I would like to add, everything from the very beginning to now, all the questions, if the patient is sitting, most of the time, like, we ask the patient to, like, please have a seat, and the interpreter will be standing. In that case, even height matters. So I found that people don't like to watch at the towards, like above and explain. So that is kind of, I think Dr. Mikoder would be more appropriate to answer that part.
Yeah, the ideal setup is not always possible in a doctor's visit, but yeah, you do want to have, if possible, everybody kind of on the same level, looking at one another. And often it works well if the interpreter stands or sits near the clinician. So you can make eye contact with the patient when they're speaking to the interpreter, and that they're not both, like, looking away from you when they speak.
So we're at 3:57. We're so appreciative of our speakers, of the many folks who contributed to creating these glossaries, in particular our language teams and our language team leaders, and very appreciative of all the questions from the group. I do want to close out with just a few responses to questions that have come up frequently in the chat, and I think I'm really encouraged by the fact that they're all about taking this work to the next level. And so their questions are there plans to make this glossary in other languages? For example, Spanish for the Northern Triangle immigrants. Are there plans to make a glossary like this for other types of health conditions? And are there plans on doing outreach to other groups of interpreters beyond medical interpreters, for example, in court systems? I can tell the audience that we would love to do more work. We don't currently have a concrete plan to do that kind of work, but I hope that some of you are inspired by this. It's an incredibly talented group of interpreters, clinicians, healthcare administrators, and others who have joined in the audience today. And so perhaps some of you will have the opportunities to work with your communities and your colleagues to continue to work on expanding and improving our communication as healthcare providers, interpreters, and advocates. And so with that, I want to thank all of our presenters, and we will formally end the presentation today. Thank you all so much.